Okay, so now moving ahead with the infectious part. So there are many illnesses that present with fever and rash. So we are moving with the infections and discussing various illnesses. So fever with rash or exanthematous illnesses. So coming to various definitions to understand them better, exanthema, it is the eruptions in the skin. Ananthema, it is the eruption of the mucosa. Macule, it is non-palpable. Papule, it is palpable. Nodule, it is larger and palpable lesion. Vesicle, it is filled with fluid, and bullae, large filled with fluids. So these are the representation. Now, if a patient comes with fever and rash, we have to ask in the history what are the preceding symptoms before the rashes, how the rashes evolve, and what are the associated symptoms with the rash, or is if there was any exposure to the infectious person, insects, or animals. If there is a history of travel, time of the year when he went to travel, and drug exposure, if any. Now, after taking the history, you have to examine the patient about the nature of the rash, as I told you in various definitions. What is the type of rash? What is the distribution? If there are mucosal or conjunctival lesions, lymph node palpable, or any hepatosplenomegaly, involvement of the genitalia, CNS, and diurnal variation of the fever. So it is broadly, fever with rash is broadly classified as centrally distributed maculopapular, peripheral, confluent, desquamated erythema, vesiculobullous, urticaria, or purpuric. The examples of central distributed maculopapular rashes are, it can be drug induced or viral. So these are measles. These are the presentation. This is the presentation of measles. The rashes can be seen over the face, over the trunk, or over the palm and in oral mucosa. This is rubella. So mainly in measles, the rashes start from the trunk. So this is rubella. Rashes are also in the trunk. There will not be high-grade fever. Rashes are scattered. Fever disappears when the rash disappears. Rashes are mainly occipital and epitrochlear. Lymph nodes appears. No significant coryza. It is of shorter duration and it is benign disease. Though if it affects the pregnant female, then the fetus can be affected by rubella syndrome, congenital rubella syndrome. So lymph nodes are palpable, mainly occipital and epitrochlear. This is roseola or fifth day disease, and these are, and it is caused due to HSV6. Rash appears on 4th and 5th days. It is called 6 disease, may cause febrile seizures, encephalitis, or aseptic meningitis. Erythema infectiosum is 5th disease, and roseola is 6th disease. Fever for 3 to 5 days. Rashes are mainly on over the face. It is lace-like reticular rashes. This is a drug rash. Now the features of drug rash, features can present with itching, ananthem, rhinorrhea, conjunctivitis, and increase in eosinophil and Ig levels. Itching is very severe. Rhinorrhea, conjunctivitis is uncommon. Now peripheral rash with fever. The examples are secondary syphilis, hand, foot, and mouth disease, which is very common in children. Dengue, both central and peripheral, erythema multiforme. These are the dengue rash, morbilliform rashes. Now coming to HSV, it can be caused by HSV1 or 2. Type of infection, primary infection, HSV seronegative, no pre-existing immunity, non-primary first infection, already infected with one type but first time infected with other type. Recurrent infection, virus from latent infection periodically reactivate, spread by direct contact between skin and mucosa. These are the lesions of herpes simplex infection. It is usually unilateral. Now coming to fever with diffuse erythema and desquamation. It can be scarlet fever, which is not seen nowadays, Kawasaki disease, which is very common, and COVID can also present with atypical Kawasaki. Streptococcal toxic shock syndrome, streptococcal toxic shock syndrome, streptococcal toxic shock syndrome, and SSSS, that is Staphylococcus scarlet skin syndrome. This is strawberry tongue and scarlet fever. This is Kawasaki, non-purulent conjunctivitis with swelling of the peripheries, followed by peeling, and again strawberry tongue. Now coming to purpuric eruption with fever. It can be due to meningococcemia, viral infection like Coxsackie, A19, Ecovirus, Epstein-Barr virus, atypical measles, dengue, hemorrhagic fever, and bacteremia. This is a presentation of acute meningococcal, which is not so uncommon. You can see large ecchymotic rashes here. Now coming to fever with inflammation of subcutaneous tissues. Causes of if infection or inflammation of the subcutaneous tissue occurs, it is called erythema nodosum. The causes can be idiopathic, infectious due to various bacteria or viruses, medicines, SLE, various connective tissue disorders, inflammatory bowel syndrome, and malignancy. Now coming to chickenpox. The agent is varicella zoster virus. The virus human transmission, direct period of infectivity 2 days before onset of rash until all the lesions are prested. Secondary attack rate 90%, age 5 to 9 years. Season usually between January and May. Now clinical presentation, the incubation period is 10 to 21 days and usually preceded by a mild fever for 1 to 2 days, then followed by an eruptive phase comprising of rashes initially on face and trunk, then centripetal distribution. So the pattern of rashes can be macule followed by formation of papule, teardrop, vesicles, cloudy, and then crusting happens. Pleomorphism is an unique feature of chicken pox with the presence of lesions in different stages of development. This is the pleomorphic rash of chickenpox. Complications of the chickenpox, encephalitis, pneumonia. It can be hemorrhage, hepatitis, pancreatitis, nephritis. It can affect all the organs. If it occurs in the first trimester, there can be embryopathy, limb hypoplasia, and near birth, it can cause to congenital varicella. Coming to the management, it is mainly clinical. The diagnosis is mainly clinical. ELISA can detect antibodies or viral isolation. Viral culture can be done, but it is very longer procedures to cultivate the virus. Treatment mainly supportive. In antipyretic, no aspirin should be given. This can lead to bleeding, acyclovir in severe cases. Antipruritic agents, prevention by immunization, passive immunization, immunoglobulins, newborn seronegative pregnant women, and to the immunocompromised persons. That's all.